I predicted that if you get good coordination across those functions, you're going to waste less time. You're going to be able to schedule faster turnaround times because there's less lost. It's higher quality communication and driven by a common set of goals and respectful interaction. So I thought that would be interesting because people would ask me, you know, very skeptical colleagues, usually in any academic setting, and at MIT in particular, how do we know this isn't just a Southwest thing and that it would apply somewhere else? Maybe it's just this one kind of unique company that's driving all these results. And so I thought, well, why don't I, you know, maybe look at this in another industry? So here I was about in the middle of the dissertation when I was starting to, you know, present some of the early findings, and I was in the hospital having a baby. And my baby is now very big. But I thought, this is exactly the same thing going on. I mean, really, it's identical. I mean, of course, not exactly, but it is a complex division of labor. There are lives at stake. And it's actually a lot more complex because each patient is more different than each flight is different. There are certainly weather conditions that vary, but patients are, you know, there's more complexity, there's more input uncertainty. And I thought, well, if anything, those factors should mean that relational coordination matters even more. Because the more complex, the harder it is to carry out coordination strictly through pre-programming. You need more feedback and so on. So these more information-rich forms of coordination should be more important the more complex and highly interdependent is the work process. And we talked about that last night at dinner. So it turns out people were already thinking, I mean, this is a few years after I started my study, but people were really noticing at a high level in the industry that we have a problem with fragmentation and coordination in this industry. The current system shows too little cooperation and teamwork. Instead, each discipline and type of organization tends to defend its authority at the expense of the total system's function. So that's exactly the kind of what Herb Simon, this Nobel Prize laureate in org theory, calls sub-goal optimization. That you're optimizing the sub-goal often due to the bureaucratic structure of the organization and the reward structure and so on, rather than the ultimate goal, which might be a well patient with no excess resource utilization. The Commonwealth Fund also noted in a major nationwide study of physicians that the most common quality problems that were reported by physicians could be traced back to coordination issues. So that, and I've heard this more recently as I've been out speaking and people say, you know, we really haven't solved the safety problem as indicated by some of the more recent studies that error rates have not gone down even with all the attention to patient error. And one of the hypotheses that's out here when I was out there when I was presenting early January to the Institute for Healthcare Improvement is safety is still seen more as each person getting their job right and not enough still at about the handoffs, which is often, it's really at those junctures where the opportunity for error is most often introduced. So it could be that focusing more on the work process will give more safe outcomes than just focusing on individual kind of human factor reliability issues. So when I started doing these interviews, this one was at the Brigham. I remember this was one of my first interviews with there the chief of orthopedics was Clem Sledge. He was about to retire, but he had been a real advocate for nurse-physician communication. And one of his statements was the communication line just wasn't there. We thought it was, but it wasn't. We talk to nurses every day, but we aren't really communicating. Most physicians won't really come out and say that, but I thought it was kind of cool. He was retiring, so I think he could say whatever he wanted. And then this was a clinical nurse specialist at MGH who pretty much said the same thing. Miscommunication between the physician and nurse is common because so many things are happening so quickly. You know, so with this compressed length of stay, they were seeing, if anything, coordination problems were getting more acute. But because patients are in and out so quickly, it's even more important to communicate well. So I think what's happened in a sense was that these missed communications have been there for a long time, but the criticality of them has been heightened by the compressed length of stay and by the recognition that we can't just go for quality outcomes, but we have to also use resources efficiently. And so that has really made more apparent just like in airlines, as they're trying to get the turnaround time at the gate down because they're now competing on costs and not just quality, it's becoming more apparent that they need to figure out the coordination, because it's easier to coordinate, an hour turnaround than a 20-minute or 30-minute turnaround. You have a lot more things going on in parallel and a lot more feedback loops, and need to keep people need to coordinate in a more timely way. So I thought I would carry out this study in the hospital setting, and I did orthopedics, joint replacement patients in particular, not because it's the most complex thing for sure, and not because I thought that's where the biggest impact would be found, but because it was pretty well understood what was driving surgical outcomes. They had a nice model, and the people at the Brigham really had developed a really good risk-adjusted model of joint replacement outcomes and good measures for the clinical outcomes, the WOMAC, which is the measure of joint pain and functioning. It would be a good place to be able to identify if there was an organizational effect going on, like relational coordination. You could find it because the rest of the model was pretty well specified. So I thought there's a good place to start. So I got 9 hospitals involved from New York, Boston, and Dallas, and chose those that were high volume and that had pretty good reputations for joint replacement, and that's probably why they were high volume. But I got relational coordination, this network measure. I was able to do the survey with physicians, nurses, physical therapists, social workers, and case managers. And I mentioned that my highest response rates, I think, were from the physicians, and that's in part because the orthopedic surgeon at each site was a co-PI, and I think if I had been wise and had done the same thing in partnership with the nursing leadership, I would have gotten higher response rates across the board. But it was sufficient. I think it was 62% was the patient response rate. Relational coordination was 51%. And then I measured quality and efficiency outcomes using, kind of best practices and doing the risk adjustment that was called for in the literature. And not all the variables are here in terms of we have gender, marital status, psychological well-being, race, and so on, in addition to the key ones, which were patient age, comorbid conditions, preoperative pain and functioning, and the volume that was being done in each of these units. And the real critical findings here are at the top, that for length of stay, there was a expected 33% reduction in the length of stay. If I'm remembering correctly the interpretation of the coefficients, patient satisfaction was significantly impacted in a positive way, and both pain and mobility at the 6-week mark were positively impacted, though less significant, but it was in the desirable direction. And when you include those as an index, there is this is the scatter plot that results across these hospitals where, again, quality and efficiency are both positively associated with higher levels of relational coordination across these clinical groups. And so I've since then worked with others to extend these findings in other healthcare settings. We did a study at Newton Wellesley where the relational coordination was measured at the level of the individual patient, and we were particularly interested in looking at patients with a hospitalist versus patients without a hospitalist. And so not only did we find that the relational coordination was associated with shorter lengths of stay, lower total costs, fewer readmits, and in 7 days and 30 days. We also found that the hospitalists had significantly higher relational coordination, specifically with the nurses, the therapists, social workers, and other specialists, in part because of the co-location and the way they had really they had selected and trained their particular set of hospitalists to really focus on teamwork. So that was just showing that relational coordination did have an impact on important outcomes in medical care units, and that required very much more sophisticated risk adjustment, because this is a really a major mix of, we used I can't even describe right now the methodology, but to risk adjust for a much more diverse patient population than if you're just looking at joint replacements. And it was some 3M, it was a risk adjustment that compared those patients to all patients in Massachusetts with similar conditions, so we had an expected versus actual length of stay. and same with total costs and readmits. So then I've more recently done a study of nurses in particular with Donna Haven-Sullivan and her colleagues. She's at UNC Chapel Hill, and Joe Vasey at Penn State. And I think it was the Geisinger system, but